and welcome to Conversations with. I'm Courtney.
And I'm Keith.
And we are the clinical team here at Burtons Academy. With our combined passion for monitoring and ventilation, we're here to rewind and remind you on the foundations and principles used to form the knowledge and understanding in everyday anaesthesia. And in this week's episode, we're talking about capnography. And Keith, I know this is one of your favourite topics. So before we get started, I thought just for our listeners, we might clarify just some terms around capnography. So we've got normocapnia. So this is when we have a CO2 of 35 to 45 millimetres of mercury. So anything below 35 millimetres of mercury is called hypocapnia. So it's less than 35, and anything over 45 millimetres of mercury is called hypercapnia. So I thought just to set the scene before we get started, just to go and clarify through those terms. So Keith, I know this is one of your favourite topics, and I know that you have a few bugbears around lingo. So why should we really care about CO2 levels in the body? Why are we not just getting rid of CO2?
Yeah, I think to answer that question, you have to go back a few steps from where you just started. So you just gave some examples of end-tidal values of CO2 in our exhaled breath, as you know. Over a certain limit is hypercapnia, and below a certain limit, hypocapnia. So we're starting at the end there. That's where breath is expelled from the body. And yeah, I think that the traditional teaching is that, you take oxygen in, you metabolize sugars, proteins, fats, produce carbon dioxide as a byproduct, and you get rid of the CO2. And to some extent, you do get rid of CO2, but you're not really getting rid of it. What you're actually doing is allowing some of that CO2 to escape from the body in a controlled way. And that's the point. It is a very controlled way. And it's controlled because the retention of CO2 is very important in the body. You don't want to get your PA CO2, your arterial level of CO2, to zero, because that would mean that there would be no buffering system in the blood. You'd have no bicarbonate. You wouldn't have anything to maintain a stable pH. So I think I know I'm going back a long way here, sort of basic physiology, but what we're really saying is that all animals produce CO2 at a pretty constant rate, unless you're exercising excessively. But if you're sessile, sat down or whatever, or anaesthetized, you're producing CO2 at a constant rate. So there's this constant production of CO2, and that gets carried by the blood. And by going into the blood and being carried to the lungs, it has an effect on the pH of blood, and that's the very thing that the body controls incredibly closely. So we're looking at a pH in the blood of sort of 7.35 as a sort of basic standard value. So we don't want to add CO2 to that and not get rid of the body, because we'll drop our pH, and by dropping our pH, we can affect all those enzyme cascades and effects that occur all throughout the body. So they're very much dependent on the pH being correct. So we're going to put some CO2 into the blood, or it's going to pick it up from the tissues. And the tendency would be, if that's retained, to alter the pH. So we're going to let some of that go when we get to the lungs, so we're not going to affect our blood pH too much. So we've got this great sort of system of producing some CO2 and getting rid of it in a balanced fashion. And that's basically what capnography is about. We're looking to see whether our system is balanced. And if it is balanced, then we get the expected end-tidal CO2 value. So I think, does that give it a slightly different slant? So it's
CO2 isn't the bad guy in this case. We're not rushing to get rid of it because it's really bad for our body. We're monitoring and making sure it's at a nice normal level so that our body is still in a homeostatic state, really. So it's not the bad guy.
Exactly, which is why hypocapnia can be, in the long term, just as bad as hypercapnia.
Absolutely. So we really need that CO2 to maintain and regulate the blood's pH. And we're just using capnography as a way to measure this.
To assess whether that regulation is correct. That's what we're doing with it. Yeah. And so when we see a high end-tidal CO2, what we're basically inferring from that is that the balance is shifted, so that there is there's too much CO2 in the blood, there's insufficient removal from the blood, so we've got this high CO2 value. So we would need to increase our ventilation to reduce that CO2 and redress the balance.
Okay, so we're using the lungs as the way to finally control and regulate the excess amount of CO2.
Exactly, yes.
Yeah, that's a very different way to kind of, what we think, what we're taught. We
Yeah,
kind
I
of think
think
that's probably one of the big myths.
I think so. I think one of the sort of feelings you get when you're taught at school or even at university is that CO2 is produced as a byproduct of respiration, cellular respiration, and you have to get rid of it. Well,
Mhm.
that implies, really, doesn't it, that CO2 is a bad thing? But
Mm.
far from it. CO2 is very much a requirement of the normal respiratory behavior of an animal. So it's not you don't have to get rid of all the CO2, and if you did, it would be a bad thing. So yeah, I think just going back to basics, thinking about what CO2 is all about, gives you maybe a better understanding of what's going on when the lungs and the heart are trying to control CO2 levels.
It's very, very interesting. It's a very different way to think. So if we are now monitoring capnography in our anaesthetized patients, like why should we be doing this then? Like, we know that we want to keep the blood pH nice and normal, but why really in our anaesthetized patients? What makes it normal and abnormal? What gives us this hyper and hypocapnia in anesthesia? Why should we really monitor capnography?
There's two parts to that question: is why does it happen, and having happened, what do we do
Mm-hmm.
about it? Because if we don't act, what are the consequences? So why does it happen? And I think again, is really quite a very simple process. We have this, as I said, constant production of CO2 in the tissues that's taken to the blood. And then there's through cardiac output, there's a constant delivery to the lungs. And then at the lungs, we've got the exchange of CO2, and we have, ventilation in its broadest sense, breathing in and out, and that takes the CO2 and removes the excess to the atmosphere. So we've got three processes. We've got production, we've got distribution, cardiac output, and then we've got removal. And those three need to be in balance. So if they're all in line, so the production, the delivery, and the removal are all constant, then we have constant CO2. Anything that disrupts one of those three elements is going to lead to a change. So
Yeah,
if, for
absolutely.
example, we said CO2 production in the body went up, so which is an unusual event, but it does happen if you exercise, furiously, or you do have an elevated temperature, like with sepsis or something like that. If your CO2 production goes up, but your cardiac output remains the same, and your ventilation rate remains the same, you can see, I think, that you've got excess production. You can end up with an increased CO2 level in the lungs. So we'll see a hypercapnia just by the imbalance now created between those three compartments. And similarly, if that CO2 level, CO2 production in the body dropped, then we'd see a reduction in the CO2 in the lungs. So any one of those three elements is going to affect what appears at the lungs. And our job as anaesthetists is to determine which of those three elements has occurred. Now, I took one example of production. It's probably the least likely thing to change during an anaesthetic, because the animal's at a constant temperature. It's unlikely to have hyperthermia or particularly hypothermia, because it's in a nice warm anaesthetic theatre. So that's the one that's least likely to change. Cardiac output may change, and we can talk about this possibly at some future event. But if cardiac output dropped, for example, if you were doing a ruptured diaphragm repair in a cat and you were stitching up, but you failed to get all the air out of the chest, you can get effectively a cardiac tamponade effect happening on that heart. And as you're trying to ventilate it, you're actually squeezing the heart. You'll reduce cardiac output, and you can actually see, because you reduce cardiac output, the CO2 will drop, and that'll be a very, very good indicator if you're trying to stitch up a diaphragm where you're doing a repair in a cat. If that CO2 starts to drop rapidly, you're having an effect on cardiac output. So the anaesthetist there would say, okay, this drop in cardiac output isn't because it's suddenly gone hypothermic. That's stable. It could be because it's excessively breathing, but I can see it's not. So we must have a cardiac output effect. So just by understanding what those three compartments do, you can predict, how things change. And they have, the way we pick up that change is in the end-tidal CO2, by picking up the CO2 value in the expired breath. And then, as part of your question, I think what's wrong with it? You have to think, well, what's wrong with a bit of hypercapnia? And to some extent, a little bit, there isn't too much wrong. But if you get a sustained hypercapnia, then you really do start to have shifts in acid, base changes in the blood, which do affect the pH and all those enzyme reactions. And it does lend itself to cardiac hypercontractility or irritability. It has an effect on the cardiac muscle and behavior. It's more prone to arrhythmias. You also have effects on blood perfusion in the brain, and control of cerebral blood flow is very much dominated by CO2. So there are a whole host of knock-on effects of that CO2 coming out of range. So
it is quite amazing that we have a look at our number on a screen and we see a nice normal number or a really abnormal number, and we forget, I think, sometimes that, say, a CO2 of 55 to 60, because our patient is hypoventilating, that there are actually going to be global effects in the body because of that.
Absolutely. Yeah. There has to be. And if it's for a few minutes, it probably is of absolutely no consequence. But if it's sustained, or the body's in a weak position to deal with those changes. So if you've got an animal that's susceptible to, it's already, say, septic, or you've got like a pyometra, you've got a degree of sepsis going on, these are all going to add to it. So the imbalance that you get with a septic animal is going to be made worse by a hypercapnia. And a prolonged hypercapnia is going to lead indeed to a respiratory acidosis. So, they're tolerable for a while, but if they are persistent, they will have some very, very deleterious effects on the patient.
And are we talking persistent being more than kind of 5 minutes? We're talking maybe a prolonged hypercapnia that lasts over 30 minutes because we're not actioning something. Is that when we start to see those changes?
Well, yes and no. I think it depends. It does very much depend on the patient involved and also the species. And I think one of the things that we see with problems with rabbits is that they can often be hypercapnic because traditionally they've been underventilated and on something like TP systems, where basically the T piece is under. The gas flow is too low, really, for the minute volume of a rabbit. A lot of rabbits, I think, are running at a degree of hypercapnia. And if they're hypercapnic for 30 minutes during a castrator or an exploratory or something like that, then at the end, when you take them off the anaesthetic, they remain hypercapnic. And I think that has a knock-on effect on how long it takes for some of these rabbits to wake up. Because CO2 is a narcotic, and levels, and at extreme levels, obviously, it will completely cease brain function, but it is a basic narcotic, and at lower levels, hypercapnia is going to lead to reduced or increased times to wake up from an anaesthetic. So there are all sorts of degrees, and I think it's very difficult to say, oh, hypercapnia is okay for 5 minutes, but it's not okay for 10. I think you have to look at your patient and say, hypercapnia is occurring here. This is a vulnerable patient for all sorts of reasons, or actually, no, this is a bit straight. I've nearly finished. Yes, it's a little bit hypercapnic. This is going to be fine. You have to assess it, I think, and it's not possible to say there's a 5-minute cutoff or a 10-minute cutoff.
Because it's very rare, I think, like in my monitoring experience, that you just get this hypocapnia and nothing else happening in the patient. I find that there's definitely other things going on with the patient as well. So we're not waiting for 5 or 10 minutes to action the hypercapnia. There's probably something else happening to the patient. Yeah, maybe their anesthesia, maybe the depth of anesthesia is a bit deep. Therefore, they're dulled to the response of taking more breaths to get rid of that excess CO2. And so perhaps we need, because our patient's too deep, not only are they hypoventilating, maybe their blood pressure is low as well. So I think we have to look at everything. Yeah.
Yeah, and I think one of my professors at the university said one thing that always stuck with me: common things are common. So if basically you've got a hypercapnia, the most common thing is that animal is effectively hypoventilating. A very fancy word in a way for just saying it's not breathing well enough.
Yeah.
And by well enough, either it's not taking enough breath per minute, or it's just not taking deep enough breaths. So so if we see hypercapnia, let's look for the obvious things. Is it underventilating? In other words, should we just give it an extra puff on the bag, fill up its lungs, and actually get rid of some of that CO2? And if that's not curative, is there an underlying reason why it's hypoventilating? Is it too deep? Is the anaesthetic too deep? Is it there some other cause? Is there blood loss? What else is going on? So capnography is the tip of an iceberg. And basically you're looking at the tip point, and then you need to explore further and look below the sea level and see all the bits that make up the picture of the base of that iceberg and try and work out what's going on.
So in terms of when you were talking about monitoring carbon dioxide levels, so looking at our capnograph, and you were talking about maybe there's a reduction in cardiac output that is actually reducing our CO2 value, how does cardiac output, how can you see that on your capnograph? If I have a bitch spay that's bleeding, and I'm thinking, okay, now I can see the usual things. We're becoming hypotensive. We are becoming tachycardic because the bitch spay is bleeding. Why is the blood loss, or why is that lack of cardiac output? How is that affecting our capnography? Is that because there's not enough perfusion getting into the tissue to pick up that CO2, to bring it back to the heart, back to the lungs to be exhaled? Is that why we might see a hypocapnia in a patient with a reduction in cardiac output?
I think it is a matter of timing and the rapidity of that effect. So the real sort of striking change in capnography in terms of the end-tidal CO2 is when I say cardiac output, we're really talking about the delivery of blood through the lungs. So if you're looking at an end-tidal CO2 of 40 millimeters of mercury and a very nice outline capnogram, and this is during the thoracotomy, and the surgeon at that point pushes his hand down to push the heart out of the wave or whatever it is, and embarrasses that function of the heart, causing a reduction in pulmonary output, cardiac output through the pulmonary artery, then basically you're going to see a rapid drop in CO2. So your CO2 will go from 45 and drop to maybe, 30, say, or 20. You'll see a rapid drop, because that's a true reflection of the cardiac output change, because of a change in the amount of blood flow into the lung in each stroke. So the stroke volume is affected, With your bleeding animal, your stroke volume is unlikely to be affected until it gets profoundly hypovolemic. So you're not going to see that that's not going to be a trigger for an indicator of a bleed. That's just going to be something that you won't see. You see other effects before you would see the capnography effect.
And I guess in those patients that perhaps they do have this profound bleeding, just because it's not arriving at the lungs to be exhaled doesn't mean the production has changed within the body. It just doesn't have a means to get to the lungs to be exhaled.
If you've got reduction in cardiac output, that's correct. The production will remain the same if there's a bleed. And I think with a bitch spay bleed, you wouldn't see a change in the end-tidal CO2 until it became severely hypovolemic. But a lot of other things would happen before that. So the reduction in cardiac output is less common again. So I think changes in production are very uncommon. I think changes in cardiac output are uncommon. Or tending towards very uncommon. So the one that really we're concentrating on when we're looking at capnography is hypoventilation. And I'd like to think about that in terms of minute volume. I talk to a lot of nurses, a lot of vets. A lot of people don't think in terms of minute volume. They think in terms of tidal volume. So, if the animal's not breathing enough, we make the breath bigger. Well, you don't have to make the breath bigger. If it's breathing 15 times a minute on its own, it really needs to be driven 18 times a minute with the same volume. That would just increase its minute volume by, 15, 10, 20%. So it's minute volume that we need to look at. And that's probably the most, all common things being common, that's what we look at. Hypercapnia means hypoventilation. We need to increase that patient's minute volume.
And so just to remind,
off topic there a bit.
No, that's okay. I thought it might be a good time to remind people that we do have a calculation for minute volume as well, and that minute volume is a product of the respiratory rate times the tidal volume. So
exactly.
Yeah, and we can't think of tidal volume without thinking how many times in a minute they do that, and vice versa. So we have to go back to the beginning of the calculation and think minute volume is made up of the tidal volume and the respiratory rate.
Yeah, and I think thinking about minute volume really comes into its own when you're thinking about a ventilated patient. then you have to think about those things independently, and you actually use real numbers. When the animal is spontaneously breathing, you don't have those numbers to hand because you don't know what the volume is. You know what the frequency is, but the concept is still there. If they're hypercapnic, they are hypoventilating. The minute volume is too low. So we think in terms of minute volume. What can we do for a spontaneously breathing animal that's hypoventilating? Basically, you squeeze the bag, don't you? You give it an extra breath or extra 2 breaths per minute, and you increase that minute volume yourself.
By changing that rate ever so slightly.
Yes.
Very, very, very interesting. Okay, so if we are talking about ventilation, we can assess patients' ventilations by looking at their capnography waveform?
Absolutely, yeah, and that's the real window to what's going on. There's the efficiency of our ventilation is being reflected by the end-tidal value.
Okay, so I always find the waveform quite interesting, and I think when I had to learn waveforms, I always just tried to breathe with the patient and try and mimic what the waveform looked like. And I thought, oh gosh, I'm taking a lot of short, sharp breaths. Maybe my patient, is also, that's how they're actually breathing. So we are taught that there's different phases within our waveform, and I know we can't exactly draw or show people a waveform while we talk about it, but if we had to start walking and talking through the different phases of the waveform, does the waveform begin at 0 for you, which is inspiration, or does the waveform begin at phase 1, which is when we start to expire, or do you think it's not as black and white as inspiring and expiring up and down on the waveform?
I think this brings into the question of exactly what we're seeing on a capnogram. I think one we have to be very, very clear about is that when the CO2 goes up on a capnogram, when you're looking on a piece of equipment, what that means is that the CO2 is going up, and that's the only thing you can say about it categorically. It probably means the animal is breathing out. But a rising CO2, doesn't always mean it's expiration. I think that's one of the things that capnography lets us down a little bit, and there are ways to overcome this, and we can talk about this in perhaps another podcast. But essentially, rising CO2 is a rising CO2. I would like to start in the capnogram at phase 0, which is actually the point where we've got the highest amount of CO2, so really at our end point. Then we have phase 0 where we breathe in, and it should drop to 0. The CO2 level should come very, very quickly down, because if you think about it, whether they're breathing spontaneously room air or whether they're intubated and have got a circuit connected to them, there's a little bit of dead space. But as they start to breathe in, that dead space which retains the remains of the CO2 that's just been breathed out gets pulled back in very quickly, replaced by the fresh gas that's coming in. And so you see a very, very rapid return to 0. So your starting point, I think, for phase 0 is you look at the end tidal point and you see a very quick drop, and it should go to 0. If it doesn't go to 0, there's some reasons why that isn't the case, and we can either discuss that here or maybe another time. Then as the animal keeps breathing in fresh air, that remains at 0 over the course of time, and then there comes a point where the animal then starts to breathe out. And then we don't see a rise at that point. What we basically see at that point is all that fresh gas that's sat in the dead space of the animal, in the trachea, the bronchioles, starts to move back up now in the other direction, picked up by the capnograph as 0% CO2 because it's fresh gas. And then we start to see, as the alveoli start to empty, a slow rise. And that's our phase 2 then. We're starting to see rise in CO2. And then we get a mixing of all those different regions of the lung until we got proper alveolar gas coming out, which we move into phase 3. And then phase 3.
And that's our plateau.
And that's our plateau, a gently sloping plateau to the end point where we start phase 0 again.
Yeah. Okay. So we've got 4 phases to our capnograph, and it starts really with, it goes 0, 1, 2, and 3. So 0, we're taking a breath. Phase 1, we start to expire and clear those dead space gases. And in phase 2, we've got mixing of dead space gases and alveoli. So we start to have quite a rapid rise there before we plateau out.
Usually that starts to be a rapid rise, and then we start, these are the things that we can start building on. That should be a rapid rise because we're breathing out quickly with those alveoli are emptying all collectively, and then starting to push on little bits of dead space towards bronchioles, but eventually all that dead dead space, fresh gas, air has been pushed forward, and we've got alveolar gas. Now, if that process is slowed down, then we start to see a change in slope. Instead of rising quickly, it rises much more slowly, and we start to see that what we call the shark fin effect. And we'd see that typically when there's something that restricts expiration. And that starts to make sense, because if you can't breathe out as quickly or as easily as you would expect to, those alveoli can't empty like they should do. So your slope's going to get less upright and become more leaning over. So we start to see those effects. So the capnograph tells us an awful lot of information.
So it's not just the number at the end we're looking for. We can actually then look at the shape of the capnograph, look at the angles and the slopes, and then gain some information of whether there is a bit of expiratory resistance, perhaps. Absolutely, we can actually use looking between phase 2 and 3. That's when we're starting to expire. And so because that should be a nice steep upward stroke before it plateaus, if we do have a really slow slope, that's almost like our patient kind of going, so they're having a problem expiring. That could be, I guess, a kinked tube. There's a bit of resistance there, or a bit of mucus in the ET tube. So just something in the way, or an asthmatic patient, something in the way of expiring that's taking that extra bit of resistance, and it's changing the slope of our waveform. So we could actually use our waveform to get another idea of perhaps what's happening in our ET tube, or our breathing system's kinked. Maybe it's a dental procedure and suddenly the capnograph has changed. It's changed the way it looks. So we could use that information. It's not just the number, really.
No, exactly. And when you see that resistance, that's going to be subdivided into two possible causes: extrinsic or intrinsic. And intrinsic, you're absolutely right. You've got some lung pathology that's hampering expiration, or you've actually got an extrinsic cause, which is like a kinked tube, a mucus blob, or anything that might hinder that expiration. So we've got two possible causes, and then in that clinical situation, very easy to eliminate the external kinked tube or the blob of mucus or whatever, and or confirm a problem with the emptying of the lungs because of like a bronchial constriction, an asthmatic type condition. So yes, that helps us a lot. It points us to there's a problem, and then we can identify where that problem is, and then we can deal with that problem.
So we're looking at, we've understood, why the number's important, and now we're kind of understanding actually the waveform is just as important.
The waveform is highly important, yes. Yeah. And there's a certain amount of information in the numbers. Obviously there is, and as we explained, it reflects the adequacy of ventilation as a overall for the patient. But that waveform then tells you the character of that that ventilation and how well that animal is able to breathe in and out. And also then there's more information there. If we had, for example, a poorly set up T-piece system. So we all know that the T-piece really should be set, the fresh gas flow on a T-piece should be set to 2 to 3 times minute volume. So shall we say we've got an animal that needs a minute volume of, 1 litre per minute, and we're on a T-piece, so it should be at 3 litres a minute, but say it's set at 2. What could happen there if the animal's breathing rapidly? In other words, there's no expiratory pauses. It'll breathe in, it'll breathe out, and then as it breathes out, some of the fresh gas will start pushing it down the expiratory limb, but it's going to breathe in again very quickly. And it breathes in so quickly that it pulls some of that CO2 back in from the expiratory limb along with the fresh gas. And therefore, what we're going to see then is, as it breathes in on that phase 0, we're going to see the phase 0 drop, and then it's going to go back up again as it sees that CO2. And this is what the point I was making earlier on. That CO2 going back up isn't a second expiratory breath. That's an actual inspiration, but it's going up. The CO2 is going up because we're actually rebreathing CO2. So we get a little blip, a little sort of double kink. So the character of our capnogram is beginning to tell us things like rebreathing possibilities. And this is probably another topic, dead space and rebreathing, but that rebreathing is as a consequence of inadequate gas flow. And that's a very, very different characteristic from rebreathing because of something like straightforward dead space. And I think that's probably a topic for another podcast. But I think the essence here is that the character and behavior of our capnogram tells us an awful lot about how that animal is breathing, how well it's breathing, and how easy it's finding it to breathe out or breathe in, and what it's breathing out and what it's breathing in. So there's a huge amount of information. We've only a couple of examples, but those are the types of things in capnography that where we can really pick up what's going on with the animal's respiration and ventilation.
Mm-hmm. And then I think I've definitely seen some errors in my capnograph before where, for example, like once you start to understand the different phases and what they mean, let's say we're focusing on phase 3 of the capnograph. So that's the plateau. So that's where you get that really nice flat plateau of CO2. Mm-hmm. And I've actually seen mine before not really reach a plateau before. And I've realized that that's because I have a leak in my breathing system and the ET tube cuff has, let a bit of air out. Maybe there's a slow leak. And I've also seen where I've had the fresh gas flow rate way too high, that the top, that should be a nice smooth plateau in phase 3 is actually this bumpy little plateau because I've got this fresh gas flow whizzing past the sensor and disrupting that nice bit of breath. So there's so much we can gain from that waveform then.
Yeah, there is. And I think to mention one other thing, you have to some extent, take into account the way that the CO2 is being measured. So you've got our two processes. We've got a mainstream capnograph and we've got a side stream capnograph. Now, a mainstream capnograph is obviously where the animal's breathing through a tube, which is sensing across that tube, and it's connected right at the end of the ET tube. So there's no delay in seeing what's happening. And the side stream is where you're taking off a sample of the gas down a long tube and doing an analysis a little way away. And there's obviously a delay going on there. But both have their problems, because if you imagine a mainstream capnograph that has maybe a dead space, even if it's on like the neonatal connector, if it's got a dead space of 1 to 2 mils, that's significant if the breath of the animal is only 4 to 5 mils. Okay, so if we've got a 500-gram kitten and we're breathing into something that's got a dead space of 2 mils, we're actually going to not see a nice crisp waveform, just like you explained, because there's effectively a dilution. We're going to start to see, instead of a nice plateau phase, it's going to start to look rounded off and look more like molehills. Okay, and if we see molehills, then basically we know what we're actually looking at is not a true representation of what's happening in that patient. We've got an effect there from our monitoring apparatus, which is imposing a different appearance to the capnogram, not a true reflection then of what's actually happening in the patient. And that's the same as side stream sampling. If you have a human monitor or a monitor that's got a very high side stream sampling rate of, say, 200 mils per second, and you're sucking off 200 mils per second, 200 mils per minute, you're sucking off 3 mils per second. That's a significant amount, again, in an animal that breathes out in 1 second and then breathes out 4 mils or 5 mils. You're taking a huge amount out, and there will inevitably be a dilution of that. So you'll start to see molehills again. So if you see molehills, basically something is wrong with the assessment technique of the capnography. Basically, the equipment is too big for the side of animal you're actually trying to monitor. And then we have to be very careful, because we still get an end-tidal value reported by our capnograph, but it's a falsely reduced one. So if we see, it's looking quite good, it's only about 35 millimeters of mercury, 38. But if we've got molehills, the real value could be anything, and we have no way of predicting what that could be. It could be as high as 50. So yes, the character of the capnogram is really important. And if you start to see disturbances in it and rounding off, then yes, a leak is one possible explanation, but also we're trying to monitor an animal on our side stream, which is taking too much away from the circuit, or we're trying to monitor on a mainstream, which has got too high a dead space. So absolutely right. The morphology of that capnogram is incredibly informative.
And it definitely sounds like there's each different phase can tell you something a little bit different as well. So instead of, I know when I was kind of trying to learn, I tried to breathe like the patient. Actually, way back then, if I had just taken a step back and understood what each part actually meant, I probably would have saved myself quite a bit of time and troubleshooting, instead of just memorizing the waveform, just actually understanding where each part of that waveform comes from, I could have saved myself quite a lot of hassle. I was just able to troubleshoot straight away like that, just because I understood what the waveform was.
Yeah, and I think this is part of what these podcasts are about. We want to explain why capnography is important and how you use it, so that when you meet a new situation, you don't have to remember what that situation is. You can deduce from, in that situation, deduce what's leading to those effects.
Mm-hmm.
So, yeah.
It's kind of like detective work, like problem solving. You think, well, that bit's normal, so therefore maybe let's look at that bit then.
Exactly. Yeah. So whenever you look at you look at an odd number, a value, you go back to your production, your cardiac output, and your elimination, and you kind of work out very quickly what might be going on. You zone in on elimination, and you look at the capnogram itself and say, actually, that looks perfectly normal. Everything's spot on. This is purely a hyperventilating animal. If it doesn't look normal and you've got molehills, then actually basically we've got something else going on. We're not sampling properly. We maybe got a big leak. We need to attend to it. It was okay, now it's not, so something really has changed. So it's an analytical process that you go through, but you need to have basic understanding of what these different parts mean, so that you can put all these pieces together.
It's kind of like anesthesia as a whole, really, isn't it? It's just one big puzzle. But this is like a puzzle within a puzzle. If we're looking at capnography, it's about fitting the pieces together for our patient.
Absolutely. Yeah. So it's a combination of all those things. Your equipment's got to be right. Your delivery system has got to be right. Your apparatus has got to be correct. And your monitoring technique has got to be correct as well. And if all those things are correct, then we can very, very heavily rely on the information we get. And there's a huge amount of information in capnography. We've touched on a very small part of it, but we're talking about time capnography. There's volume capnography. We can extend that and use volume capnography to tell us things about dead space values within the lung, and almost down to the point of breath-to-breath alveolar dead space values, which becomes really, really important in things like horses. I think tendencies we tend to talk a lot about small animal. There's a huge amount of information in there that can be used for things like dead space evaluation, breath to breath on for horses, and that's something I've been working on for a few years to develop that technology in some of the anesthetic and ventilator machines I've been working on. So capnography has a huge part to play. And I think in this podcast we kind of covered the general aspects of it, but there's a lot more to think about. We really need to think about CO2 transport. We need to think about oxygen transport and the interaction between those two. Partial pressure of oxygen in the lung, partial pressure of oxygen in tissues, how the two interact. And I think this is possibly subject of a future podcast. But just to give you and our listeners an idea that capnography is an incredibly powerful tool, and we can use it at all sorts of levels. We can use it at a very basic level with numbers. You can use it as sort of numbers plus outline of the capnogram, or we can start to use it in a very, very sophisticated way to look at these dead space values and get a lot of information about the way that the body is behaving. But at the end of the day, what we really want to do is achieve and confirm a status quo within our patient that is just like it was when we anesthetized it, that everything is as it should be. And that's really what we're trying to prove and achieve.
Oh, so much more than just a number then.
Yes.
It's so much more. And I mean, I know we've touched mainly on traditional capnography. So, it's the line of the graph, and it's either a filled line, it's just a line, or it's a filled box. But actually, something for one of our future podcasts, we'll get to kind of delve into a bit of color-coded capnography, which is it is not quite a new thing. It is extremely new in vet med. So if we have our waveform that's kind of just telling us that there's CO2 somewhere in the breath, we don't actually know if they're rebreathing that in, or maybe they've stopped breathing, if they've finished their exhalation and it's just sitting at the sensor's just picking up what's just left sitting around in that sample port. So there's something can you give anyone a little bit of a taster on what color-coded capnography that we could perhaps talk about in another episode?
Absolutely. So what I've described previously, we talked about phase 3 and how it led into phase 0, and that's a very neat concept. But bear in mind that when we breathe out and when patients breathe out, we don't automatically start breathing in again. So we'll breathe out, then there's a pause, and then we breathe in. So that expiratory pause. So what happens in the expiratory pause? That's a very, very interesting thing, depending on a lot of factors. Would determine what you see on the capnogram. But let's just take a very simple example. Let's take a circle system where animals spontaneously breathe. There's no ventilator. We're just spontaneously breathing. Animal breathes out. The capnogram level goes up. The trace rises. We get a plateau phase, auto expiration. And then we've got a significant pause. The animal's going to just wait before it starts inspiration. Well, that CO2 level will just be maintained. It would look like a continuation of the plateau, but there's no air movement at that point. It's just the CO2 is held there because it stopped moving, and this graph is just measuring what's there, which is all the dead space and all the tubing that's surrounding the capnograph sensing area is full of CO2 until the next breath. So we just get a perpetuation of that phase 3, and then the animal takes a breath. We get that normal phase 0 drop down. But our length of our capnogram, from the rise of phase 2 to the fall of phase 0, we've got no idea really, just by looking at the trace, when expiration ended and when inspiration started. Well, we think we know when inspiration started, and that's also a slightly another story. So there's some hidden things going on in the capnogram that you can't always pick up. But just say we had a mechanism of knowing when, indicating when expiration ended and the pause started, then we'd actually begin to see our capnogram back in our true light again. We'd see the expiratory phase, it's phase 3, and then we see another phase, which would be the expiratory phase, or the pause expiratory phase. So there's ways we can use something called color-coded capnography, which I think we should have another podcast to talk about this, that shows us how we can actually differentiate those. I just want to throw one thing into the mix now. If we have dead space, and we haven't talked about this and we haven't got a podcast on it yet, but if we had a significant dead space, then just imagine our phase 3 line went up, went along during normal expiration, then we had a pause, and then we had inspiration, but we were actually a lot of dead space. That line would continue flat even though we had inspiration, because we had a lot of dead space and we were pulling back in CO2 from the dead space, and then it would start to fall. So now we've elongated our waveform even further, and we couldn't see that on a traditional capnogram. But if you could indicate that we'd gone from pause to inspiration, then we'd have actually delineated expiration, pause, and inspiration. And that's what color-coded capnography is about. It tells you what those phases are. And once you start to identify the flow direction of those phases, then you begin to see what's happening. And color-coded capnography will therefore pick up immediately extra dead space. It will pick up immediately, indicate whether you've got inadequate gas flow in a TP system like we previously described, because we will see that rise in CO2, that secondary rise in CO2 that I described by pulling back in CO2 that wasn't properly flushed down the expiratory limb, will actually show up as an inspiratory phase, not an expiratory phase. It very clearly delineate that. So yeah, some exciting stuff coming about color-coded capnography, and it just highlights that there's a lot of information in the CO2, but capnogram waveform, but it does hide some stuff. You need to be aware of what it's hiding, so you can actually make judgments on that as well.
Ooh, I'm quite excited for this. So we're going to be more than just a number, more than just a waveform. It's what's happening in the waveform. That's what we can, it's just another exciting thing to talk about. Okay, well, just to wrap up this podcast on capnography, what would be your biggest take-home point or just realization point about capnography that you wanted to share with everybody?
Okay, I think capnography is one of the best monitoring tools we have, and it gives you the clearest insight into how well that animal is behaving in its ventilatory and respiratory function under anesthesia. So if you disregard all other tools, focus on capnography. And I think because capnography is so important, understanding it is even more important. And this is a very introductory, casual talk about capnography, but we're very happy to provide, or we will be providing ongoing CPD or training sessions, whatever you want to call them, that does explain all these and highlight these features and show how you use them in a clinical setting. So my take-home message is capnography is your best monitoring tool if you can only have one, but it's only the best monitoring tool if you know how to use it and you know how to respond to the things that it's telling you.
Absolutely. So would it be safe to say that capnography is your desert island type of machine that you would take with you? If you could only take one thing, you would take capnography.
Absolutely.
Oh, great. Okay. Oh, well, thanks so much. That was really, really, really interesting. So I'm quite looking forward to catching up about the color-coded capnography and seeing which way the gas is actually moving and defunking the myth that up must be expiration and down must be inspiration in the waveform. So I'm quite looking forward to that. So no, thank you so much for taking the time to chat about capnography today.
No, that's good. I think it's going to be an interesting exercise to convey to people color-coded capnography, which is a very visual indicator on an audible platform. But we'll cover that when we come to that podcast.
Fantastic. Okay. Well, we'll talk again soon.
Okay. Thank you. Bye-bye.
Thanks, Keith. Bye. Thanks for listening to this week's podcast. Don't forget to follow our podcast to stay up to date with the latest episode, and feel free to share with your team. If you have any questions or feedback for us, or simply want to know more about what you've just heard, please send us an email to clinicalsupport@burtons.uk.com. Catch you next time.